Well, welcome back. Thank you. This morning was a perfect segue to our next panel, which is going to be an exciting look into very different aspects of clinical transformation with an eye towards keeping with the theme of the day, how clinicians can lead and how that will help take us forward. So my name is Kavita Patel. I'm a fellow and managing director here at the Engelberg Center and an internist by background and a primary care physician, and very excited to help moderate this panel, which means I'm going to try to be as quiet as possible, make sure you all get a chance to interact with this esteemed set of panelists. And so to that end, we have an amazing group here. Their bios and full credentials are in your packets. Without taking up too much time, I just want to do some very brief intros. And building on what both the congressman and congresswoman said, as well as some of the remarks Mark made, as well as kind of this effort around what Dr. Merkin has been a leader in the past and the present, I'd like to just say that the goal of this session, especially for our panel, is to illustrate from our different vantage points how clinical experience and how leadership has played a role in transforming these systems of care. And interestingly enough, that involves also some failures and roadblocks as well as some successes. So that's just a brief overview. So just starting all the way with your left, and then we'll work our way down. And I'll introduce folks and then ask each of them to give some brief remarks, and then we'll open it up for questions and an interactive discussion, and then move from there into our next panel. So all the way to my right and to your left is Dr. Kevin Schulman. He's the professor of medicine and the Gregory Mario and Jeremy Mario Professor of Business Administration at Duke University. Seated next to him, Dr. Elliot Lazar, Senior Vice President at New York Presbyterian Hospital. Next to him is Dr. Barbara McEnany. She's a founding practice partner of Oncology Hematology Consultants in New Mexico and a member of the American Medical Association Board of Trustees. And then immediately next to her, Ann Hendrick, who is a clinical nurse and vice president of clinical excellence operations, as well as the executive director of the Ascension Health Patient Safety Organization at Ascension Healthcare. And to my right immediately, Bruce Hammery, Dr. Bruce Hammery, executive vice president and managing partner of Geisinger Consulting Services at Geisinger Health System. And most recently, prior to that, was the chief medical officer for Geisinger Systems. So you can tell absolutely they have the bona fides and the credentials. I think more importantly, as we'll get into, each one of them have had a crucial role personally as well as professionally in really helping to not only lead and take clinical transformation into the next era, but have had to face the very question that Dr. Burgess raised, which is how do you cultivate a culture of transformation, and how do you do this? It's not easy, it's not prescribed, and as I'm confident some of them will tell you, it sometimes goes punished and it's often unfunded. So this is all done in times when resources are scarce, yet the critical mission and the need for it is at an all-time high. So Kevin, do you mind starting us off with some of your thoughts, and we'll go from there?
No, thanks, and thanks for inviting me. So I get to give the academic presentation, all theory and no practical experience. Now, actually, I run a very large research group. You know, I think when we talk about, I think there are two really essential concepts here. One is leadership, and then leadership for change. And we've obviously had lots of leadership in healthcare. We've built big institutions. We've built big infrastructure. We've created a lot of things in the healthcare delivery system. You can go anywhere in the country. In Europe, I kind of say we go visit cathedrals. In America, we come visit hospitals. The only problem is we can't afford those anymore. And so we have this question of what is leadership for transformational change? What is transformational change? And that gets back to a couple of things that we do at the business school. And the first major question is, why do people change? All of you are running successful businesses. All the people running pieces of the healthcare system are doing very well, especially compared to the rest of the economy. You wake up in the morning and, you know, we're doing pretty well. Do we want to change? When you look out in the broader economy, why do firms change? And I'm generally convinced there's only one reason why firms change, and that's because they're afraid they're going to be killed by a competitor that day. And absent that, people don't change. And so one question for the policymakers, for all of us to decide is it the super committee? Is it the deficit? Is this the final point where we have to get serious about change? And so that's one issue. If in fact we're in agreement that we have to change to be something more, One question is, what is that destination? There's a lot of different ideas about that. I go and visit Indian heart hospitals, not as an example of justice, but as an example of efficiency. So if you want bypass surgery for $2,500, you can get it in Hyderabad, India, by a surgeon who does like 3 or 4 times the volume of any surgeon in the country. All right? So there are other models out there at substantially different price points that we can observe. I will tell you also, for a 300 or 400 bed hospital in Delhi, the entire management team is about half the size of the people in this room. Obviously, there's no single committee at your institution that's smaller than double the size of the people in this room. Which brings it back to, how do firms change? And there's a vocabulary of change that we don't learn in medical school about how organizations transform. There are a variety of different ways. There's ways in which you're creating these ACO products or service line products. You have a team of people, you go off, you build a whole new infrastructure, and then you keep the old infrastructure and you have the new infrastructure. And that's called cost increasing. You've doubled the size of your firm. There's venture capital. Every single firm, every single biotech firm out there has a venture capital, or pharma firm has a venture capital arm. Why do they do that? Why do they say they do that? They're prospecting for new business models. They're not invented here, okay? We're not smart enough to figure out what the future is. Let's go find some couple people that are entrepreneurial trying to start something up and see if we like that idea, so we can bring that business model inside. Acquisitions, we're doing lots of acquisitions right now where hospitals are acquiring physician practices, whether that's to improve the efficiency of care or to have leverage against the payers is really a critical issue for us to address. So we do some of that, and that's a critical structural issue. Do we do the right kind of acquisitions? And then finally, organizational change and partnership. I'd love to say that at Duke, if you walk into our original hospital building, there's the original chairs of all the departments at the Duke Med School written in bronze in the front hall. We're an organization, we have exactly the same departments today as we did then. We're an organization with our org chart written in bronze. Okay? There is no other firm in the United States that has an org chart written in bronze. You know what the skill we don't have is? Structural reform. You know, how many of you have been in years and years of processes of moving from hospitals to service lines? Or in our firm, at the Clinical Research Institute, we got 1,300 people, and we've realized actually no one in the management team's ever been through a transformation, a structural change, okay, in their entire business career. So those are a set of skills and vocabulary we need to learn. And one other final thing we have to learn as part of that is the difference between fixed and variable costs. Almost all the policy initiatives in Washington are around variable costs. You could do a great job managing, keeping your heart failure patients out of the hospital, and you know what? The people in the hospital are still paying rent. They still have 10,000 administrators. There's still all the same organizational structures in place. We haven't done one iota to transform the business of healthcare. As part of this, how are we going to deconstruct a final thing? You want to pay for the SGR, get rid of all the administrators. Okay? There's lots of non-value-added things in healthcare that we've created over time, either because we've not filled those roles, or we haven't concentrated on those roles, or we've made this mistake of focusing on variable rather than fixed costs. If we're going to have some room for growth, both for innovation in products and innovation in service, we're going to have to tackle that fixed cost thing, and that's going to have to be a core competency of organizational innovation.
Thank you so much, Kevin. Elliot?
Sure, good morning. Thank you for having me. I'm going to build on some of the themes that Kevin spoke about, and although my remarks will be directed toward physicians, I think they really apply to just about any healthcare professional with a clinical background, be it nursing or other technical folks. And I'm going to try and frame my comments around the physician as leader and leading physicians. So let me start with the idea that the concept of a physician leader is really a heterogeneous one. We have physician leaders who are clinical leaders, educational leaders, leaders of departments, divisions, leaders of institutions, organizations, and so on and so forth. And I think you'd agree that being identified as a leader in one setting or venue doesn't necessarily mean that those skills are transmissible to another setting or venue. And we often make that mistake. Number one, the skill set may not be there. Or number two, the desire or interest may not be there. I would also, again, build on a point that Kevin made to say that the traditional medical hierarchy, and I'm going to speak a little bit about that in a moment, doesn't necessarily parallel those folks that we would ask to lead transformational change. So, a chair or chief may wind up not being the best individual to lead, say, a particular clinical initiative. There's a very young anesthesiologist who works for me. He's one of my quality and patient safety officers. He's literally in his second year out of training. Actually spent a lot of time with Dave Nash at Jefferson, and really comes to this with the right mindset. He's probably been more effective in some organizational efficiency activity than many of our more senior clinical chairs. As we think about the role of traditional physician leaders, they really, I think, fall into four specific role types. First and most desirable is when the traditional leader, the chair, division chief, and so on, becomes the champion for the effort. One of our chairs has become very passionate about the issue of the patient experience and satisfaction. She herself is the leader of the task force, attends every meeting, drives the agenda, demands the performance measures, and so on and so forth. So that really is most desirable. Unfortunately, it's not always what we have to work with. The second is where the traditional leader delegates to somebody else. So a chair may not have that particular interest, expertise, or time, but delegates somebody else in the department, another colleague. Again, we have a particular department where the vice chair is extremely passionate about reducing readmits and length of stay. The chair is not so inclined, much more interested in some of the department's basic science pursuits, but clearly has endorsed the person to whom he's delegated, has put the chairman's moniker on those activities, his imprimatur, and it's very effective. The third model is where the traditional leader is neutral. And I think many of you would agree that we deal with that by perhaps recruiting peers or other folks in a similar level to sort of champion the effort. Neutral, I think, can be dealt with indirectly. The fourth role type, which is the most problematic, is where the traditional leader is the obstructionist. Whether it's a clinical chair or president of a medical staff group or whomever, they really just don't want to see change happen. And unfortunately, in those situations, we really have no choice but to sit down with the individual and deal with them on a pretty direct basis. So let me just make one or two comments about the notion of leading physicians. So who are we dealing with? Well, we're dealing with folks that are bright, a group generally resistant to change, a group that arguably may be frustrated by either the perception of the reality of less control than they may have had in the past, a group very schooled in the use of evidence and data. So where does that leave us? Number one, transparency and honesty above all else. I think many of us have heard that our physician staff, whether in academic centers or community hospitals, question whether they're being given accurate and honest information, and that's really what they want. We have an obligation to provide it for them if we expect them to be involved in the kinds of transformation that are required. We use data, but obviously only if the data is high quality, and we have to think about it from the point of view of the critical reader. If there are issues with the data, limitations, physician attribution we hear about all the time when we're dealing with MD-level data, we've got to make that clear up front. And often the docs will challenge, but if moved by good evidence, can be compelled by it. I would close by saying that we also need to be very consistent in both message and methodology. One of the things that we hear, and I suspect we're not alone, by many of the docs is we seem to be picking the improvement process du jour. We go from this one to that one, and we don't seem to be consistent, and why should I get enfranchised if I know that a year from now somebody's going to be changing that? So consistency of both message, methodology, and leadership from the top is very important. The final point I'll make is that obviously progress is not always in the kind of, is measured in the magnitude that we look for. Desiring perfection can be the enemy of good, and I'll stop there.
Great, thank you. And I know Dr. McEnany has some slides. I'm going to hand you, and you can just forward them as you like. And
okay.
direct your attention to the easy-to-see screens in the corner.
Thank you also for inviting me to speak today. I don't represent a large integrated health system, and it's going to be my goal to convince you that it may be necessary, but it will not be sufficient to work simply with large integrated health systems because, for example, in oncology, where I live, 80% of the cancer care is delivered in private practices. And if we then make wonderful transformational changes in all of the major institutions, I would like to try to convince you that that will not be sufficient to get us where we need to go. And the first one is because a lot of patients are treated outside of large academic or vertically integrated institutions, and we need to focus on that as well. We also need very much to look at the fact that hospitals, and I agree with Kevin, are very large fixed cost institutions. And I would say that they're relatively inefficient. Hospital-based physicians tend to be not have any incentives to save costs to keep people out of the hospital. And one of the things that I'll show you as I talk through my experience is that as I started working with my hospital health plan conglomerate, bilateral monopoly systems, that they were not very interested in any of the changes that I was trying to make. And even the cost at that instance is significantly more. Even MedPAC comments that the same service purchased by a physician in a hospital-based system costs 150% of what it costs in a physician fee schedule physician. And then finally, to the workforce comments earlier, the American Society of Clinical Oncology did a study some years ago looking at the number of oncologists being produced versus the demand for need. The need will go up 148%. The number of physicians will go up 113%, which means that in about 15 years, 1 of 3 cancer patients will not see an oncologist. In order to deal with some of the issues of that, in my practice in New Mexico, one of the things that we did was we recognized that having our bilateral monopoly wanting basically to put us out of business, that we needed to become very efficient, and it was not in our best interest to have patients in the hospital. We did this years before we were worried about cost savings or anything else. So one of the things that we did was started developing a system of care which, had I known of the label at that time, I would have called an oncology medical home. But basically what we did was set it up in a way that we could keep patients out of the hospital, manage their care, proactively make sure that they tolerated all of the complicated treatments that we did for them. And then, in interest, I looked at the amount of savings that we were generating. This data that's on this one is Medicare data for 2010. This is out of one oncology practice, and it's a significant amount of money. The issue, I presented this based on the data that we could pull for one particular health plan in my market, showed it to that health plan who also owns a hospital, who said, why would we want you to cut down the amount of hospitalizations and cut down the amount of imaging you're doing and cut down of our ED use? That's not going to help us get where we want to go, which is to be more profitable. And if you have any doubts about that, look at the large number of consultants and legal firms who are working very hard to convince oncology practices to move into hospitals because they can make more money if they do that. 1/4 of oncology practices sold to hospitals last year, about 50% of cardiology practices. So there's money to be made by putting physicians into hospitals, and I would suggest that perhaps that's not where this country needs to go at this point. So I looked at this data in my practice, and this is actual data. What this is Medicare for 2010, and looked at the structures of what we could do to make a difference on that. And then I realized that this is very carefully divided. The revenue side of the ledger goes to the payers. The expense side of the ledger comes to me. And that's very useful for the payers, but it isn't sustainable in a physician practice. And therefore, I figured out that one of the things we better do is figure out how to do some different fee structures. And I have been unsuccessful. I'm one of the failures Kavita mentioned, unsuccessful at trying to sell this to any of the health plans. I did get the one health plan that didn't have a hospital in my market to actually look at this and consider my bundled payment that I would like to do. But then as soon as the hospitals got wind of this, they threatened them with a high hospital day rate, and that was the end of that. But we did create a process by which we can do a bundled payment. And I've been working on this to Congresswoman Schultz's process. It's been taking about 5 years to work through this, where we set up a way to do bundled payments that is transparent, that is sufficiently clinically and economically integrated to satisfy the antitrust requirements, and is actually a workable thing. So we would create a process by which we have reinsurance protections. My theory is that I would like to have Medicare set up an account for me and let me bundle the payments and let me manage oncology payments, the whole works, the whole continuum of care. Put that money in a reserve account that I draw down against. I would first buy some reinsurance, and I would make sure that I had good demographic loops, because a few extra folks who want to go for proton beam can break the system. You put patient stratification, and you fund the patients as you move there. You know that there are patients of multiple levels of complexity. You can come up with average payments. I can do this from my practice. You have reimbursement accounts that you can then say, I will need to put various amounts of money for each given patient, each given diagnosis and stage into specific accounts that I can then monitor, and I can keep this as a transparent system. So the best way to mess up a partnership of physicians and hospitals is to let somebody think that you're not giving them the money they're entitled to. That'll end it pretty quickly. So it has to be transparent. We can put the money into these reserve accounts. Any unused allocations then I can put into a different account and be able to use that, because not all people are exactly on the average payment, and that gives me a reserve for high complexity payments. And I can have a quality pool where I can make sure, using internal mechanisms, that patients are actually getting what patients need when they need it, so that the quality is there. And if I can do this so that I could have a bundled payment in this manner, that takes you back to the amount of money that you could save, which I showed on the previous slide. And I think doing something like that, working with the community practices, which are small enough that if you ask me how much it costs for me to do printer cartridges, I know that. And we really can get down to that level of granularity. That, I think, is where we're going to make some significant cost savings. And with the medical home part of this, my patients are thrilled not to go to the ER and sit for 6 hours. They're thrilled not to be admitted as long as the national average. They're pleased the fact that they can call us day or night. Now, one of the issues and one of the challenges we have is that the younger generation is smarter than I am, and they have figured out that they don't want to work that hard if all of the benefits are going to accrue to the payers and not to them. So it will take some degree of resources to make sure that physicians continue to be willing to work this hard. If this weekend somebody calls at 2 a.m. to be admitted, it's me. I'm there in the hospital admitting it in the morning. The issues really will be putting enough of the resources into the physician practices that they can become and continue to develop into very efficient machinery for taking care of patients and giving patients what we want. And if we do that, then we will save money in that expensive fixed cost system called the hospital. Thank you.
Thank you so much, Barbara. I think, Ann, you had some slides. Just go ahead and click next. There you go. Thanks.
Thank you. My comments and thoughts today really stem from reflecting on the Ascension Health journey to zero, and now our high reliability pursuit of clinical transformation of care. The bold goals that we set now 8 years ago to reduce preventable mortality and also to eliminate serious safety events required that we engage deeply hundreds of clinicians across our system This transformation work has shown system-wide improvement in both quality, safety, and also cost effectiveness. We are a large, complex system, and we've seen the impact this engagement has had in multiple states. Just a couple of slides here. I'll put this one up as I'm talking. We are not simply a system of hospitals. This graphic represents the complexity and the diversity of the care environments that Ascension provides for the communities that they serve in more than 20 states. It's also important to note, I think, that the majority of our physicians are not employed. In fact, very few are employed with us. Many of our physicians have partnered with our care teams in numerous ways to improve clinical care quality and improve access. They've done this by dramatically decreasing hospital-acquired conditions and also set new benchmarks in these areas for the nation around birth trauma, reducing injurious hospital falls, and in pressure ulcer prevention. We have nearly eliminated hospital-acquired pressure ulcers. These improvement efforts were not contained just within hospital settings. Similar impact can be seen in our creative disease management medical home programs in the communities that we serve that have reduced episodes of illness and also in acute care hospitalization. I want to briefly share with you a couple of examples that I think highlight this. We are one of several sites that were selected by NCI for the National Community Cancer Care Program. And as it has already been stated, as most of you know, cancer care delivery in this country, the majority of it does occur in clinics and in community-based hospitals. And that really was the focus of this initiative. How do we improve the disparate nature of oncology care delivery and reduce redundancy and, frankly, overtreatment? To no surprise, we found that when you support busy clinicians with care navigators, tremendous improvement occurs at the patient care level. There is higher quality, less cost, better patient experiences. But what I would challenge us to say is, are we still building workarounds? Because these care navigators are designed around the broken system that we currently have. So yes, it works, but it's still adding additional cost to what is a fragmented system that is in bad need of transformation already. So these findings suggest that there's sufficient complexity between subspecialists, even in our comprehensive care cancer programs. Another key finding from this work that I want to talk briefly about is to assure that palliative care teams are also part of our care models. I want to share with you briefly one of our care navigators and palliative care team members shared this story about a patient that I'll call Mary, who had been hospitalized 6 times in less than 2 months, primarily for symptomatology, because the outpatient environment did not support the care needs that she has. There was really no reimbursement for that type of care. On her 6th admission, the palliative care team simply asked Mary, "What is your goal for this hospitalization?" And she said, "I simply want to go home, to be able to die at home, to be able to take fluids and not have abdominal pain and sit on my patio." Within 3 days, the palliative care team actually made that happen for Mary. My question is, why doesn't that happen for every patient, especially at the end of life? So this case demonstrates the patient and payer impact when providers and the care team are aligned. Unfortunately, this is not easy work because the incentives right now are not aligned with the kind of care model that I just described. The last area that I'd like to talk briefly about is another example. We currently have an R18 grant with the Agency for Healthcare Research Quality, which is targeted around reforming medical liability. We have engaged 5 of our largest obstetric delivering sites, and as many of you probably know, obstetrics is one of the most litigious areas in medicine. We have trained more than 200 physicians, more than 300 nurses with ARC Team Steps training. These are obstetricians who were trained to never disclose to a mother any unexpected event because it would increase the hospital or their own medical liability. After this training, now we can say they have developed a bundle for one of the most difficult labor presentations, which is called a shoulder dystocia. And when this presentation occurs, an infant often sustains either temporary or permanent lifelong injury to the arm and the nerve in the arm, decreasing functionality for a lifetime. Our obstetricians and nurses designed a bundle of maneuvers that has actually reduced this rare event by more than 50% in the last 14 months. There have been no claims at these hospitals. Still too early to draw conclusions, but what we do know is that these obstetricians have now implemented this shoulder bundle, 5 states, 5 different models of medical malcaps, et cetera. And as one of my physician colleagues said to me recently, if I had known then what I know today, I would have been a better doctor for the last 20 years. So there is full engagement of our physician leaders, and an indirect benefit of this has been that medical premiums for these physicians have been dropped by 10 to 15% based on the work that we're doing. We've enrolled 6,500 mothers and infants in this study. We're well on our way to about 20,000, which will be one of the largest medical liability studies ever published in the literature to our knowledge. So I would encourage you to watch for that study, and we will have actuarial analysis of the liability and premiums impact over time. So in conclusion, let me say that clearly, as it has been said many times already, it is possible to fully engage physicians and nurses, and our goal at Ascension is to continue to discover how to best partner with our clinicians to lead this transformation change, and also that all of our clinicians and nurses are fully practicing within the scope of their licensure to lead this transformation.
Great, thank you so much, Ann. Bruce?
Well, good morning. Geisinger, as you know, is a physician-led integrated health system. We have physician and administrator teams who lead our organization at every level. We have not adopted the view that every physician needs to go to business school. I mean, we think there are people trained to do that. Doctors need to have some skill, but those teams share accountability for the budget of their operating unit, whether that's a service line, a division, a department, a hospital, for their budget, the levels of their quality and services, market growth. They have hire and fire responsibility for their staff. They coordinate and are responsible for both the inpatient and the ambulatory components, and they have some responsibility for the strategic planning of their area. Our physicians have led a number of the development issues. You've heard Dr. McClellan talk a moment about proven care for the acute side with cardiac. I'll mention briefly that we've done similar things in the outpatient area and in diabetes, for example, with the reliability bundle, have been able to demonstrate a 40% decrease in vascular complications, amputation, loss of vision, stroke, heart attack, within 600 days. Our OB folks have put a pathway together that extends 10 months and has reduced low birth weight admissions to our NICU by half. So our physician leaders are required at our place, and I would submit at yours, for success in changing the organization. For us, this has been about a 10-year journey. We started with an organization at that time that had an 85-year history and a number of physician leaders in place. Like some of yours, I expect many of those individuals got there because they outlived their predecessor. And so one of the things that my boss and I did was we evaluated those individuals based on performance, and over the next 2 years changed 75% of our physician leaders. 75%. Now, we don't have tenure, as my boss, who came from a medical school, said. So that's easier for us to do than perhaps for some. And we set performance expectations. We have some criteria that we use. First, Doctors have to want the job. This is not something you assign, not temporary additional duty is assigned. This is a job you have to want to do. At our place, and I suspect at yours, they need to have respect as a doctor. Your colleagues have to know that you know how to take care of patients. They have to be a good communicator. They have to have some evidence of ability to perform and lead in another setting. So we put people through committee assignments and a variety of things. And they have to be able to work in a team and respect their colleagues. So this is not a time for the neurosurgeon to yell. They also have to be willing and able to confront bad behavior by their colleagues. Most physicians are conflict avoidance. And they need to have some vision for the future and the ability to excite others about achieving that vision and do this in a way where they're not a shop steward. This is not you're representing the interests of your group against the entire organization. So we have a formal process to identify these folks. They can be self-identified during their annual evaluation. Their chief can nominate them. And we have questions for each of those on every annual evaluation. This creates a list for us as senior leaders to identify people for assignments to committees, for assignments to work groups, and a group of about 30 physicians and 30 administrators are identified each year for a seminar series that's led by our CEO and a member of our board who's a professor at a business school at a local university. Now, we find that of the people who attend that course who've expressed an interest, about a third decide they're not interested, and that's similar to other reports in the literature. We have had a number of successes with this, chief of pathology at one of our hospitals, chair of surgery, and so forth. We think you have to provide a career ladder for these people. That, you know, if you take somebody and they're going to stay in one job, they're going to be the chief of the quality operation or the chief of X forever, that is not a good option. So what do we need to get this done? One, we need a different selection and training process for our medical schools. We are all selected as best athletes, not as team players. And this is basketball, or my colleague from Duke.
Thank you.
And so it's team sport, and we have to learn to pick people who work in teams and train them that way. They need to be more process-oriented. We teach people the Krebs cycle. We don't teach them how organizations work. It does not require a business degree for everybody. Residency competencies have been changing. The ABMS, as you all know, has changed some of that. That needs to accelerate. It needs to be linked to changes in the nursing school curriculum. It needs to be linked to changes in the curricula for administrators. Administrators are still being trained as heads in beds. And as a guy who's run a couple hospitals, I can tell you that's not the future. So that concept has to change. So in effect, I would offer one other thought. Evidence-based medicine should apply not only, or EBM should apply not only to evidence-based medicine, but I think also to a concept that Steve Shortell proposed in an editorial in JAMA a few months ago, which is evidence-based management. And it's the link between those two, driven by clinicians who know their patients, know the system, that I think can really help us forward. Thank you.
Thank you so much. So I want people who have questions, go ahead and raise your hand in the audience so we can get mics to you. I just want to quickly summarize and thank our panel, but also say that I think what you've heard is reflective of a large degree of what we see in healthcare in general. There's a great deal of variation in settings, a great deal of variation, including I think it's classic, Kevin's example of these bronze outlines of chairs all the way through Bruce offering that, if people can't cut it, we let them go. And then we also find that people identify themselves as leaders, and that might not be facilitated in other settings as easily. And to Barbara's point about how do community-based practices, as well as a question that we often receive at the Engelberg Center, where do small practices fit in this very large and often confusing frame of misaligned incentives and transformation? And I think there's a very important role in clinicians thinking through all these very rapid market changes in the way we deliver health care. And then Anne reminded me at the very least how much, especially for physicians, how much malpractice and liability issues play often a really inhibiting behavioral role in the care that I think clinicians want to see. And so if I had to summarize, I would say that we can do work in Washington and or at least try to, as you heard the congressman and congresswoman point to, in realigning or fixing the misaligned incentives. But then we really need for folks like those on the panel to actually help to both lead clinicians and, as Elliot said, to also be the leaders themselves. So do people have questions? I've got some based on some comments here, but we'll just make sure we can get mics to you before you ask the question. And just please give us your name when you ask. Thank you.
Greg Paulson from Blue Cross Blue Shield Association. It's been a very interesting set of commentaries. Let me just push the envelope a little bit and ask panel members to really reflect on what changes do you really think are actually going to result in a net improvement in the value equation? In other words, where we see both some improved quality or a benefit, change, in other words, more effective care, but also that we don't, in a sense, trap the whatever efficiencies or savings we might be able to do, they're not trapped in the system. And I think Kevin's point is an incredibly important one, is that we, at every level of the system that I see, and we've all pointed at everybody, we blamed everybody. We blamed the hospitals and the insurers and the doctors and the pharmaceuticals, et cetera. And in a sense, that's partly true, because all of us have the kind of institutional structures that are not necessarily the most efficient. So how do we really break through what I think has been a real problem in terms of improving both the benefit quality side, but also the actual expenditures? Because ultimately, it's people who pay for healthcare. It's taxpayers and it's consumers. That's who pays for it. And I think we're at a point where, the alternative is no education, no roads, no whatever.
Right.
Bruce, I know you wanted to respond to anyone else who'd like to.
I think it's a great question. We've tried to format each of the approaches to satisfy the needs of at least four constituencies: the patient, the provider, the payer, and the purchaser. And we've been able to show, both with medical home model, with several of the bundles, that we can improve the patient experience and decrease their out-of-pocket costs because they have fewer copays and deductibles and all that stuff. We can provide cardiac care to our health plan at 38% below the rates they pay anybody else. We have been unable, I will tell you, to sell that to Blue Cross. Unable.
Well, there's someone here from Blue Cross.
Well, no, that's why I'm looking right at it, okay? Because at the end of the day, our health plan has taken your market share. They have lower rates because they can pass those on to the purchaser. And in fact, sometimes I show a slide of the front page of a newspaper that says local teachers got a 10% raise in pay because they switched to Geisinger Health Plan and they're paying enough less for their premiums to account for that. And our providers, we have been able, with the standardization of care, the reliability of care, to decrease our internal costs so that it really does become win-win-win-win-win. I do think that we've got to change the way that bills are handled. We have as many people in the finance office in billing as we do nurses. Now, my CFO gets upset when I say that, but I will tell you that dealing with, 42 insurance companies and the feds and the state and all that, there needs to be some alignment. And if that were one policy that came out of Congress, it would probably cut 20% off the top.
Barbara.
Yeah, I would like to address that as well, because what we've done in our practice on the ground, and we have been electronic since I shredded the charts in 2002, is we can be data driven, and we focused our entire structure around the patient. And that's what resulted in the shorter lengths of stays and everything else. We never put anybody in the hospital without a goal. We're going to fix this problem, and then you're going to come out and we're going to continue the continuum of care there. I think we're going to have to get rid of some of the fragmentation of the hospitalist who doesn't work as part of the practice. I think we do have to make sure that as we design it around the patients, our patients are thrilled with the care that they're getting, because they know that if they call us day or night, somebody is there who knows them, has their chart, knows their data. That's key. I think the other thing that I was going to mention is, since you're a payer, is that we do spend a huge amount of time, and the AMA has done remarkable work on looking at the payer report card, saying that the payers pay according to their contract about 80% of the time. Goes up and down a little bit varying on the payers, but it's not 100%. This means in my office, again, and I was going to make the same point, I have to employ a huge number of people simply to manage the money. And I employ 3 people simply to get free drug from pharma, et cetera, for when we can't provide them with chemotherapy. If the AMA numbers show that about the average physician spends, the average family practice physician is spending about 5 weeks per year working on getting prior authorizations and trying to be paid fairly for the work that they've contracted to do. So if we could eliminate that, that's another 300 patients per doctor. That will help us with some of our workforce issues. I also think disconnecting the hospitals and the physicians will be useful. I think we will swing that pendulum back in a few years because of the various things I talked about. If you're an employed physician, you're just not going to work as many patient hours as when you work for yourself. And with this shortage, we're going to need doctors working hard, seeing lots of patients. It costs more to do it hospital-based. We're going to have to figure that out and pull people back out. And we need to make this process very efficient and very patient-centered.
Elliot, and then Kevin.
Yeah, I would certainly echo what my colleagues have said, but if you take those the 4 Ps, harmonization within each silo and harmonization across the silos, I think would take us a long way. And I'll give you a couple of very, very brief examples. We provide cardiac data reporting, as many states require, but we actually have to do it in duplicate with 2 sets of analysts who are doing 2 sets of data abstraction, because one is for regulatory purposes to a regulatory body and the other is to a professional society, because that's what the payers would like us to do. We have electronic health records that are closed platforms. They don't talk to each other. Like probably all of you, I'm amazed that I can go anywhere in the world and use the card and get money, but I can't get an EKG from the guy across the street. And I think until we're able to break down some of those silos and really embrace this concept of harmonizing across same indicators, interoperability, and so on, I think it's going to be a tough road.
Can I just add to that quickly? I mean, it took, and I'm not sure they're there yet, it took, most of the large systems in Pennsylvania, Penn, Geisinger, Pitt, have the same computer system. It's taken the state 5 years to be able to take standard vaccine data and put it into their data set, and they still can't return it to us, so it's in ours. We still have to log on to their website to see this. Right. So I would just submit this starts with government.
Starts and it might stop there. Kevin?
True, that's the problem.
I
don't. I agree with Bruce. You don't need to go to. Everyone doesn't need to go to business school. Some people do, but we can't handle everyone going to business school anyway. And on that side, actually, there are very few places to go to business school and to look at healthcare. There are very few faculty that actually concentrate in this industry. There's only, we just formed a group of a whopping 10. But you know, as you see the idea of the thought that Bruce is putting into to Geisinger and how this has evolved over a decade, you know, one question that's legit is to go back and ask, is your institution doing that? And if not, why not? So, you know, we've had a conversation with 6 healthcare systems as exemplars and 5,544 that are non-exemplars. You know, within the same financial construct, we keep talking about reform, but they're doing it. It's painful, but they're doing it because that's what they decided to do as a leadership group, and they've actually structured themselves so they're like-minded people doing that. We don't have huge numbers of examples of that. We have lots of examples of leaders that build new buildings, leaders that build new whatever initiatives, they couple onto the old initiatives, and you know, and some set of transparency on that. We don't call, you know, we don't call a question. We're not publishing in the newspaper every day, this person's leading your community to ruin because of the way they're running their healthcare system. Even the boards, I don't think, understand it. One of our local hospitals voted for a 30% Blue Cross Blue Shield rate increase in terms of making an acquisition. I mean, that's the only way to justify the acquisition. So, you know, we need to have transparency and some set of accountability. These are community benefit organizations, they're not-for-profit, and clearly some of them are being run that way. Many others, it would be questionable.
We have more questions in the audience, so just, I think we had one up here, and I thought we had one back there as well.
Hi, Don Casey from Atlantic Health System in New Jersey. I know many of you and are very jealous of the accomplishments you've achieved, but relative to physician leadership, I'm interested, if you were to do one new thing that you haven't done before to enhance physician leadership in your organization, what would that one thing be if you had a wish list?
You know, I would say what Bruce is, you know, what we lack is general management, right? Our dean at our medical school ran a whole $1 million lab before she was put in charge of a $1 billion medical school right before the financial crisis. You can't think of a pathway to success that's, you know, more fraught with peril. We're not organized, you know, Bruce said we're all silos. I could be the head of quality and I could have done that for 20 years, but I'm not general manager. I have no idea what the finance guys do, or heaven forbid what the nurses do. So if you really want to have leadership of an organization, you know, you go look at what people do in other businesses. You know, this is a lot about plagiarism. Business is all about plagiarism. If you see a business model that works, copy it.
Right.
Right? And we're not socializing ourselves to that. So the idea that you get a $20 million unit, and if you do well with that, you get a $50 million, $100 million unit, means you build skills. I can test you. I can build accountability. I can give you coaching because I actually observe what you're doing in a meaningful way and help you to move forward. And that's not a process that any of us have.
Well, we do a lot of that. I think the thing I would do differently is I would rotate, and we've talked about this, I would rotate physicians in leadership to different specialties because they really need to understand the upstream and the downstream. And the cardiology guys are great, or the surgeons are great, but they have no idea what goes on in the primary care site and vice versa. They may have very little idea what goes on outside the operating room. And I think my own personal experience was that I grew up in adult infectious disease and did hospital epidemiology for 20 years. So I literally saw everything in the hospital from the roof to the sub-basement where the vacuum units were, and interacted with all the different people and all the folks in hospital administration. And you know, it's a unique perspective, and there needs to be a way to give other physicians some of that. If you look at the way hospital administrators have changed, they rotate them, right? They started out as a junior assistant, something in charge of pharmacy, and then they rotate to other areas of the hospital, and so they get that broad view. And as physicians, we don't. Once we get into a specialty, we're siloed.
But one thing that I would do is I would and it of course all costs time and money, would be to help the physicians to interact with other people who are in their role elsewhere in the country, because otherwise we tend to get very provincial. And one thing that we started up about a decade and a half ago was a little group called Oncology Circle, which was six practices our size in different markets, so that without fear of being accused of collusion, we could show data to one another. We could create data that says, what do you pay your doctors? What do you pay your nurses? How much do you buy this or that or the other thing for? How do you structure yourself to be more efficiently? We all helped one another learn. And now it's grown to 30-some practices, and we have a lot more significant data ability. But that, plus the electronic record that we all have to be in this, allows us to really look at this in a way that I could take the program that I've delivered in our practice, and I could scale that across those 30 practices in a heartbeat, because they're all kind of doing that. We're just not organized to publish it and let you know about it. So if I could get more of the doctors to be able to share that kind of data, share ideas across different sites of service, that would be fantastic.
Elliot and Ann, briefly, and then if we have another question.
Sure. I mean, there are clearly places around the country, Geisinger I think is one of them, that have extraordinarily advanced IT platforms and are able to perform the kind of analytics that are really meaningful. But if you take a broad swath of hospitals, literally across the country, every state, in the U.S., the ability of providing physicians with meaningful data that's actionable, that they can work with, is really not there. Clearly, I don't think my own place is where we would like it to be, and that would be something that I'd very much like to do. Physicians are innately competitive. I mean, that's how they got to be, sort of where they are. And there are many, many examples of, Hawthorne-style effects by simply providing docs with, comparative and benchmark data. And I'd love to see us be able to do that in a much more meaningful way. And then, of course, the issue of combining outpatient and inpatient, particularly with voluntary private practice medical staffs, is certainly a daunting challenge.
Ann?
I would just briefly echo, the one thing I would do is that when you get busy clinicians in the room is to have a powerhouse around them, supporting them, and open the books. And we just launched 5 affinity groups, orthopedics, cardiology, oncology, bariatric surgery, et cetera. And when we united clinicians from across the system, didn't know each other, some employed, some not, within a matter of minutes, they had congealed on the price point differences, just as was represented around someone who thought they were getting the best price on a screw for a joint implant, and there was a $300 difference in our own system for a screw that looks like it comes from Home Depot. So, give them the support they need to make those critical decisions and ask the questions. And they said, let's go after this together. I don't mean to oversimplify it, but it is giving them the information they need to transform practice.
So we're up on time, and we're not taking a break, but I want to, before we thank our panelists, just set up for our next panel, which is on payment reform. You're going to hear a lot of the same threads. Something that we'll work on at Brookings is finding a way to cross all these issues in promoting pathways to do this. And I can't emphasize and underscore something each of you have said around the role of training kind of the next generation of clinicians writ large. When I was doing this, there was no one I could look to say, here's a pathway for transforming clinical care, and here's how you do it. And it's not that simple, but we need to see more models like theirs. So please join me in thanking our panelists.